Hi, everyone. Good afternoon. It's a pleasure to be with you. So I'm going to talk about mostly on quantitative CT imaging today. I'm going to give you some clinical challenges and then an approach of solving this using in silico data or virtual imaging trials. So here's my disclosure. Many of the work that have been done for this work is funded by National Institute of Health, and I hope that that would be still true in the following months. We don't know. Any work that I present today is a work of our lab. So I want to acknowledge my colleagues at Duke University who work with me and they collaborated on many of the work that I present today. So let me start with relevance of quantitative CT. You probably know CT quantifications are known, have been used, are predictive of disease severity. Let me give you one example. In COPD, which is a lung disorder, there are different categories in which a patient can get diagnosed with. The exposure of being smoking cigarettes or involved in like a chemical environment. Their symptoms, spirometry or lung function test, and CT imaging can also reflect a patient abnormality in the lungs. So in a study, they have shown that each of these four items could sort of predict diseases and the severity of it. And with and without imaging, they have shown that there is a significant difference in terms of the lung function and also mortality. So which means that if a patient has all the symptoms and the lung function test and also being exposed, if they have been diagnosed with the quantitative imaging and not CT imaging, there's a significant gap. So that sort of relates to why we need CT imaging and how it can bring insight. The challenge is that CT imagings are often sensitive to parameters and scanner mix and models. So which means that when you're quantifying data, depending on what scanner you're using or what parameter you have been using, those numbers might be different. So that would be a major concern for both cross-sectional studies and longitudinal studies. In cross-sectional studies, not every sort of hospital would use the same protocol. And in longitudinal studies, the technology would change. So that's a huge concern. Let me give you a visual example. This is what I'm showing you a CT image of one patient for one particular scan. And the only difference in the four images is that that patient was reconstructed with four different conditions, two different reconstruction kernels and two different voxel sizes. And the histogram that you're looking at is the histogram of the lungs for these four images. And then the highlighted regions are what a clinical biomarker that are used for detecting emphysema, something very relevant for COPD imaging. So that highly shows that for just using a different reconstruction kernel of voxel size, how inaccurate and imprecise your measurements could be. Let me give you another example. Let's say you have a patient, they got an image, a baseline image with a regular dose, a smooth reconstruction kernel, and we measure their emphysema score using quantitative imaging. The patient comes back after 5 years, the protocol has changed, so they had to use a different dose and a different reconstruction kernel. And we quantify the emphysema score again, and we get 26%. The baseline was 11%, so there's a 15% difference. The issue is that we don't know if this is a progression or if this is because of the change in the scanner protocol. For the very same patient, we happen to have another scan after 5 years, which was with regular dose, smooth kernel, and the emphysema score was actually 11%. So if I go back and forth, for two different dose levels, I see different numbers. So that sort of shows how challenging this quantitative CT imaging could be, although we have shown benefits of it. If we don't understand how to use it precisely, they will not be reliable and robust. So what are the solutions? One solution would be, so let's optimize our acquisition. If we understand how imaging parameters are impacting our quantifications, if we know which parameters would lead to more accurate results, let's use those. And then those solutions might be scanner specific for different technologies. You might find different sort of acquisition parameters that are optimum. And those parameters might be patient informed as well. Patient themselves might impact the accuracy of the quantification. So we need to have an understanding of that in advance to be able to optimize those parameters. The other aspect is that how about the way that we do the quantifications? In the example I showed you, there was a very simple way of measuring emphysema through thresholding. That by itself could impose inaccuracy in our measurement. So is there a way to improve the robustness of our quantifications? And the other approach might be that, okay, it would be nice to have optimized acquisition and optimized quantification, but what if my data is retrospectively acquired? And if I don't have control over the protocol, I am given this data and I know it's not imaged with the perfect or the correct reconstruction technique or dose level. What can I do at that point? So retrospectively, there could be other solutions like harmonizing images so that those two images at two different time points or with two different imaging technologies can be related to one another. So I'm going to go through each of these steps in my today talk and show you some examples of how each of these can be developed. But before go there, for any of these experiments, how do we do this? How do we evaluate and optimize? Physical phantoms would be one, that I put a phantom, I understand different protocols and their impact on quantifications. And with this, I can use this for acquisition and optimizations. The challenge is that it's not anthropomorphic, so it doesn't reflect really patients who are going to be imaged with that scanner. They're not disease specific. It doesn't mimic the pathology, the task that I want to optimize for. And you don't get the diversity. Even if it's perfect and anthropomorphic and has disease inside that phantom, it's only one patient. But I want to have a solution for a population. So that's going to be a challenge. Ideally, you would use clinical trials in which you image patients across the diverse attributes of disease, severity, age, sex, and so forth. The challenge there is that you don't know the ground truth necessarily with these patients. You don't know how much emphysema they have. You don't know how much, what's the size of their lungs, or if there's motion in the patient or not, what's the true density. These images are expensive to acquire. If you want to study different settings, you need repeated imaging. That's also not viable through patient images. You cannot image a patient three different ways. There's a radiation dose concern. And scanner availability is another challenge. Let's say you want to study a new scanner. You might not have that scanner in your clinic, so you might not be able to do that experiment. So the whole idea of doing virtual trials is to facilitate this, to provide a mechanism in which you have control over providing a population of patients with anthropomorphism, with disease specificity, having it diverse, and not being worried about the ground truth or the expense or the radiation dose concern, and so forth. So what does it mean? In virtual imaging trial, we create this population of patients, we mimic their anatomy and physiology, we image them with a model of scanners, mimicking the geometry, acquisition, physics, post-processing, image formation of a particular scanner that we want to study. And then with that, we have a mechanism in which we can do our imaging experiment. So I'm going to briefly introduce the first two components, virtual patients and virtual scanners, and some of the work that we have done over the past few years. So you know what I mean by virtual patients, diseases, and scanner simulations, and so forth. And then at the end of my talk, I'm going to show you how these resources can help us to answer that quantitative CT question that I brought up in my earlier talk. Virtual patients have been developed for more than 50 years now. Many researchers have worked on this over the years, and these phantoms have been developed and been getting more and more anthropomorphic. One of those groups is us, that we are working on creating these what we call XCAT or extended cardiothoracic phantoms. These phantoms are patient specific. It includes various organs and highly detailed structures from muscles, vasculature, skeleton system. So they create these anatomical models to reflect patients' attributes. These are patients, so we create these off of a large variety of human beings from their CT scans. So with this, we can replicate the heterogeneity and the diversity of what you see in your patient population. One of the recent advancements that we have had is to create intra-organ structures. As traditionally, these human models have been developed to have organs that are patient-specific and reflect the anthropomorphism of what you see in patients, though because of the imaging system challenges, you would not be able to extract intra-organ structures like vasculature system or different heterogeneity or texture within the parenchyma of a particular organ. So some of the work that we have done is to how can we create these anatomical models that are based on anatomy and then based on morphometry of these organs to create these very detailed intra-organ structures so that you can use it for image quality assessments if very tiny vasculatures or airways are needed in your imaging experiments. We have done this for various structures like parenchyma and vasculatures in the lungs. We have done it in the bone and some other organs as well. So this is one area that we have been working on to create these human models more and more detailed within their organs. Motion is another feature that is quite important to us. When you are imaging a patient, there's always a cardiac motion that you need to deal with. Often patients also have respiratory motions during acquisition. That respiratory motion could be incidental or just having a regular breathing. And then here I'm showing you one of those examples of you're looking at a human model. This is just a phantom. It's not a real CT image. And you see that the lungs and the cardiac part can also, sorry, this is not moving. Oh, now there we go. So there's a cardiac motion, there's a respiratory motion. These are based on 4D CT and MRI data. There's a parameterized, so we can change their respiratory rate, heart rate, the amount of diaphragm movement. All of these are controllable. So then you can use it for studies in which temporal resolution or motion matters. Modeling disease is also quite important. We often do our imaging for not healthy patients, but rather disease patients. So with this, we need to be able to create these models across different diseases. I'm showing you a few examples on our efforts on creating cardiac plaques, COVID pneumonia, COPD, including emphysema and bronchitis, and liver lesions and lesions across different organs as well. So in short, human models would reflect or represent anatomical distribution and geometrical attributes of a patient with their physiology and pathology, in which then you can have this patient population in which you can do your study. The next step is modeling the scanner itself that you want to study. And we divide a scanner simulation into three pieces. The first part is you would model the acquisition system. So what is the geometry of that scanner, the size of the detector, size of the source, how it rotates, all the acquisition details that you have within your simulation. And then what's the physics to the X-ray spectrum, physics to the detector itself, and so forth. The second step is to model the simulation itself. In this case, it's going to be that when there is an X-ray source and then you emit these photons, it interacts with the patient body, and then there would be some interactions, and it would then hit the detector. You simulate all this process to get the X-ray primary signal, the scatter signal, or estimate the dose that would be absorbed to the patient. So that's your second module, in which you calculate all these interactions. And the third would be the image formation. So as you get the sinogram, How do you combine these images to each other? How do you add noise? How do you account for the model of the detector? How do you do the post-processing? All these corrections like beam hardening and so forth would happen, and then reconstruction stage. So that would be your third model of any sort of simulations that you do in for the imaging part. One of the CT simulations out there that we have developed recently is called DukeSim. It's a GPU-based CT simulator. Essentially, it generates projection data, CT projection data. It has a Monte Carlo module that gives you the scatter and dose estimations. There's a ray tracing engine, which gives you the primary signal. And I don't go to the details, though. Just want to highlight that it mimics some of the latest modern attributes and features of a CT scanner, in which you can then use it for studying particular clinical imaging experiments. And it works with both energy integrating and photon counting detectors. That helps us to study also this latest CT technology of photon counting CT. So that's essentially an introduction and a summary of how a CT simulation would work. We have done validations, which means that we have taken physical standard phantoms to the clinic, imaged with different scanners, different imaging parameters, and then reconstructed that data. We create a virtual version of that and simulate those acquisitions exactly with the attributes of that scanner and parameters. And then we compare the two images in terms of both qualitatively, but just visually make sure that images look to one another, and also quantitatively, that if they have close image quality attributes. So here is one of the examples, and on the top you see one of the standard physical phantom on the top, replica of its simulations on the bottom at different dose levels. And just visually speaking, we see that the images look to one another and they sort of have similar trends in terms of noise or spatial resolution or contrast. And we have done this, as I said, across various scanners and in terms of quantitative image quality metrics. Here I'm showing you one example on one of the photon counting scanners that we have validated at Duke. Anything blue is simulations, anything red is experimental data. Y-axis here are different image quality metrics. That the left one is noise magnitude, the middle one is noise power spectrum, texture of the noise, the right one is CT number, intensity values, HU values. And as I said, we have done it for multiple scanners and multiple phantoms. We also done it with an anthropomorphic shape sort of phantom as well, to just make sure that it reflects what you would see in an experimental measurement with a real scanner. Similar here, blue is simulations, red is real data. So this was a very quick sort of summary of two of the tools that we need for visual imaging trials: human models with the detailed anatomy, and scanner models with the detailed physics and image formation of what you have in the clinic. So now let's go back to the problem that we wanted to solve. In the earlier part of my talk, I mentioned that CT quantifications are important, but they are imprecise because of the imaging scanner. So we wanted to sort of solve that solution. And as we discussed, optimizing acquisition was one approach. So this is one of the work that we have used our virtual trials tools to answer this. So essentially what we did is that we took 20 of our human models with different severity of emphysema. Here you see the yellow regions inside the lung reflect the emphysema models. That these are based on patient data, by the way, the models and the diseases. So we took these patients, we imaged them with 3 different scanner types, photon counting and 2 clinical energy integrating systems. And we imaged it with a bunch of different imaging parameters, different dose levels, different reconstruction settings, and so forth. And then, knowing the ground truth, knowing exactly how much emphysema we put there and then exactly what's the definition of the density for each of these phantoms, we were able to compare the ground truth versus the ground truth versus simulated CT images in terms of quantitative CT for density. So what I said is you can see it as the results here. The y-axis is the mean absolute error of emphysema measurements inside the lungs. Different columns here reflect different sort of attributes. So here, the first column is about radiation dose, reconstruction algorithm, kernel, slice thickness, and pixel size. Different color are three different CT systems. And then here you see the comparison. So if I just want to pick one, I can maybe let's look at the radiation dose. You see on the green scanner, the photon counting scanner, as you decrease the dose level, your error would go up. So you go from like 40 HU error up to 56 HU level. So this essentially would give you a map of what would be the better kernel to use, what would be the better reconstruction technique to use, and how are they inconsistent with one another from one scanner to another one. This is a study that I could not do with real patients. I cannot ask a patient to get image with three different scanners, three different dose levels, and then do all these studies. And even if I can, I don't know the truth value, so I cannot really measure the errors in their density of the lungs. So when we do these sort of trials and we understand they're useful, but we also want to make sure that it relates to what you see in the clinic. So in that sense, we want to make sure there is some sort of validations. And here I'm showing you those validation results. What we did was that, yes, I cannot image a patient multiple times, but if I have imaged a patient, I can access to their CT sinogram and reconstruct that with different reconstruction conditions. And then maybe I can compare that with my simulated data and see if they follow similar trends. And this is what we did here. Here, blue is simulations, orange is clinical data. And then we saw that when you change different conditions, which is your column, we had similar sort of trends as far as how different imaging quantifications would change by changing from one kernel to another kernel or from one dose level, from one pixel size to another pixel size. So that gives us some more confidence that the simulation findings that we have also some relevance in what you see in the clinical data. So this is sort of how you can approach the protocol optimization from a parameter standpoint. There's also the patient attribute in which you can study. Again, specific to lung imaging, the lung volume itself makes a huge difference in how you measure density. If the lung volume changes, that would change the density of it and thereby would change the density measurements that you have. So the study that we did was, we had our XCAT phantom. You see one example on the left. We can change the XCAT phantom respiration level. So we changed the respiration level from 100% to 70%. And at different respiration levels, we did a CT imaging, and then we quantified those. And that's the sort of on the y-axis here, you would see that those blue dots show you those quantifications. Ideally, if our quantification is robust, y-axis is delta or variability. So I should get only 0. So it shouldn't really matter what the lung volume is if my goal is to measure something from this patient. And this is a known fact, and there are corrections techniques for it. So there is, without going to the details, there's a physiological technique to correct for this. There's a statistical technique for correcting for this. These techniques can also be evaluated using our tool. So here we have shown the effectiveness of a statistical technique and physiological technique is sort of correcting that variability of the measurement that you get just because of the patient attribute or different lung volumes. So that sort of shows another utility of how you can use these resources to study some patient attributes specificity. Okay, so those are two examples on the optimization of patient attribute, understanding patient attributes and image acquisition. Let me give you one example on how we can do the quantification by itself. Historically, the way we quantify lungs in CT is we look into the density. And as I mentioned earlier, it is not robust to different parameters because their noise is different or the spatial resolution is different. So one thought would be, can we improve this instead of using a simple threshold? What if I can segment emphysema? Yes, it's a challenging task, but if I segment it and show it would be robust to those variations, then that should be an improved way of doing my quantifications and things would be more robust. So we sort of enable this by training a network and deep learning network on our visual data to learn how to segment emphysema. So essentially, we had those patient models I showed you, imaged it with DukeSim at different dose levels, different conditions, and this gives us a perfect sort of reference with CT data in which we can train and learn how to segment emphysema with it. And then in the end, we sort of complemented this data with some clinical images in which we were able to fine-tune the segmentations with clinical data so we can be confident that these network that we train can also work on clinical cases. So essentially the simulation data will help us to, as a starting point of learning how to segment emphysema with a lot of cases and a lot of conditions. And then the clinical data help us to sort of fine-tune this and learn how to apply this in clinical cases. And this is one of the results that we have here. This is our, as I said, network trained on simulated data. And this is tested on a clinical data from a COPD gene study. On top, you see the traditional quantifications, which is threshold-based and intensity-based. Different columns are different imaging conditions. This is same patient, so it should ideally, all of this should be the same segmentation everywhere, right? So you see how unreliable the emphysema measurement is on top when you do simple thresholding. And the bottom is our segmentation, and it's much more accurately identifying the emphysema regions regardless of the imaging condition. So with this, you would be able to get these emphysema measurements much more accurately. And we also showed that this would correlate with visual scores or the way that radiologists also score a CT image on their emphysema severity. Okay, so I briefly talked about the optimizations and also mentioned how we, on the acquisition side and also on the quantification side. But what if we don't have access to the acquisitions prospectively and we are with the data that's already acquired? Is there any hope for harmonizing these images retrospectively so they can relate them to one another? So as I said, remember this example. 5 years ago, a patient was imaged. After 5 years, there's a different scanner. Can I harmonize these two images so that I can do this comparison and be able to answer the question that did this patient progress or not as far as the severity of emphysema? So what we have done is that we developed a physics-based harmonization framework. And the idea was to transform CT images to a reference image quality. We already know that image quality is the essence of the reason that these images are different in terms of their quantification. So what if we transform these images into a reference image quality? And at that point, at that level, those quantifications should be more comparable. I'm not going to go into the details of the method, but essentially the work is we do some voxel resampling, we do some spatial resolution matching, some noise matching, and then with this, we would be able to get more accurate measurement, more consistent and harmonized measurements across different imaging conditions. This is one example of one patient. Oh, sorry, before showing you the results, when we were developing this tool, I want to relate it to what the benefits of virtual trials. we were able to test each of these methods with our virtual trial data sets because those were giving us sort of a diverse imaging conditions and ground truth in which we can test whether our algorithm is working or not. But now applied on patient cases and clinical cases. This is one example, a patient with low dose and a relatively sharp kernel with a emphysema score of 16%. And the target dose here, this patient was imaged twice. So I also have another condition for this patient. So that same day, that patient also was imaged with a regular dose and then smoother kernels. And this is essentially what I want. This is at the dose level that we want to harmonize for. So I want to see that if I have my left image as an input, and if I run my harmonizer, would I get an image would give me a emphysema score that is closer to the right one, the ground truth in which I image that patient with. So, or in another word, as far as quantifications of the histogram, can I go from this red histogram to this green histogram, which is for the higher dose? And this is our results, show that with this harmonization, we are getting with only spatial resolution matching, we are able to get this sort of quantification closer. And then by doing the noise matching and the next steps, we are getting very close to what you see as a reference image. So essentially, this approach helps us to make these density measurements much more harmonized and consistent with one another. And this is some sort of results across a population of patients, a few hundreds of cases from COPD gene. Particularly if you look at the middle row, those are Bland-Altman plot or the variability plot. So essentially the idea is that the lower the variability, the better, meaning that for each patient, two different conditions were less different from one another as far as their CT quantification. And we showed that after harmonization, the right column, things are less variable. And this is essentially what we want retrospectively. So if I have still time, I can quickly give you a few other examples outside of this example. Arman, do I have time?
Absolutely. Absolutely.
Okay. Short examples is going to be very quick. Just want to give you some idea of like this can also be applied to different applications. I mainly talked about lung density quantification just as an example, but that doesn't mean that our tools can also be applied to this. One idea was nodule characterization. Radiomics is very important. We know how much it can characterize specific attributes of lesions, growth, and speculations, and so forth. So in which we can study how different CT systems or conditions would impact those accuracies. So in another word, if let's say you have on the left the ground truth human model with the perfect sort of lesions that I'm showing you, if I image it with an energy integrating scanner, the example on the middle, and a photon scanner on the right one, how are these compared? How are these being impacted as far as the radiomics features and so forth? In short, we have observed that radiation dose, for example, doesn't impact morphology measurements. Not surprised, we were expecting this. But we saw that reconstruction parameters matter. Like using a sharp kernel is actually very helpful because you can see all the edges and so forth. And then we also saw that comparing photon counting versus energy integrating, which is the orange plots versus the blue plots, the errors were less in photon countings because they have higher resolutions. And then as you increase the slice thickness, which I'm showing you from left to right, the errors goes higher. And that's also obvious because you are sort of reducing the spatial resolution and adding more partial volume effect. Similar observation with kernel sharpness. Use a sharper kernel is better. Your errors would go down. And across all conditions, we saw a higher resolution photon counting scanner is better. So essentially, photon counting outperformed energy integrating CT, and we were able to quantify that in the context of radiomics measurements. And same with the previous example, as I said, we want to look into clinical data versus simulated data and see if they follow similar trends. And this is one of those examples that by changing slice thickness or reconstruction kernels, we observe sort of similar findings and orders of magnitude of difference when you go from one condition to another, from comparing real to simulations. Another example is liver nodule detection. In CT, it's a challenging task to detect liver lesions because first, they are small, second, they are low contrast. So it's hard to find them, and it's very relevant to and important to find these lesions. So one question is that how can I condition my CT imaging, or if there's any difference between different technologies as far as finding these lesions? So we have done two sort of work. One is that as far as image quality, we compare different imaging conditions. Here is on the y-axis, I'm showing a detectability index. It's a quantitative metric in which it shows the likelihood of a lesion being detected. So the higher the detectability, it means that that image has a higher chance of being detected for the lesions for a radiologist. And x-axis is different conditions, different dose levels, photon counting versus energy integrating, and different kernels. So with this, we are able to identify the conditions in which the detectability index would be higher. And we observed that low dose scans negatively impacted the liver lesion detections, which essentially highlights that although it's good to go after low dose for making our patients safe, but we are imaging the patients for a diagnostic reason. So we need to make sure that the dose, the choice for dose actually matters, and we do not drop the dose to a level that is not diagnostically relevant. For this study, the detectability index was a quantitative metric. So we had those images, we quantified this with an index. What we did also is that these simulated images, these volumetric images, were shown to 4 radiologists. They didn't know what they were looking at. They didn't know the imaging condition or the scanner technology. We asked them to detect lesions. So we said that we are going to show you some volumetric CT images, go through them. If you think there is a lesion, click on the lesion. And with this, we were able to sort of quantify their performance across different conditions and do these comparisons also in the context of a radiologist and not just a quantitative image quality metric. And here is the result. This actually work was published, I think a week ago. So I want to highlight a few things here. One is that these are radiologist results. The two is the 86% versus 73% is their performance on the energy integrating scanner for low dose versus routine dose. So just by changing a routine dose to a low dose, it dropped their performance by 13%. And that's quite high. So we need to be very careful on the dose levels that we choose for liver nodule detections. And this drop was actually even higher or more for lesions that were below 1 centimeter. So for those more challenging cases, that dropping the dose has actually a much more adverse impact. And of course, we can also compare photon counting versus energy integrating. We saw some sort of similar trend that they outperform, but they outperform even better in the more challenging cases when the dose is low, or when the lesions are quite small. So some take-home points. I hope that I gave you some examples that show visual trials could be a solution to our limitations to conduct imaging experiments because of cost, time, or ground truth, and answer to these rapid advancements in technology developments. Some of these applications I demonstrated through quantitative CT, and there's a lot to be done. There are different groups that are also doing great work in this area. I think we need to keep working on our models to make sure they are more realistic and representative. You can only do these studies to the extent that you have realistic model for. If I do not have a realistic model of a lesion, then my studies would not be even relevant. So I hope that we would have more of these developments, adding more diseases, adding more diversity to the patients, and more attributes. There's a lot of applications that can be used. Then there are diverse imaging modalities that we could study. Everything I said today was CT, but that doesn't mean that CT is the only imaging modality that this can be used. In fact, Dr. Rahmim and so many other groups have used this technology and idea for different modalities, and it's being done, and it should be, I think, expanded upon. And I hope that some of these sort of CT quantification diagnostic can be extended to treatment and outcome prediction. So it's not that we are only improving quantitative measurements, but rather we're also through that enabling more precise patient-informed and patient-specific treatment plans or help with their prediction of the outcomes and essentially helping with healthcare and patient care. So with this, I would like to once again thank my colleague at Duke University and also highlight that some of the work that I mentioned, the resources that we have are available for use. This is our website. You can check it out. We also have monthly forums, and all of those are also there in the forums. You can go and check out our talks, some of them by our group and other experts from different sort of area. And yes, thanks for listening and happy to answer any questions that you might have.